Patricia Dykes is here, a professor of medicine at the Harvard Medical School and a research program director at Brigham and Women's Hospital in Boston. And she's going to share with us a very personal and inspiring story. So please welcome Patricia Dykes.
Almost 40 years ago, I lost a patient after what was supposed to be routine surgery, not because we didn't care, but because we didn't see it coming. I still remember his face like it was yesterday. I was a young nurse, I was eager, I was dedicated, I was doing the very best for my patients. Tom was recovering from routine spinal surgery. On the first day, he was bright, he was pleasant, he was even joking with me. It was a textbook recovery. Everything looked good. His vital signs were normal, his pain was controlled, and I expected to see the same bright man the next day. But when I walked into his room the next morning, something was different. Tom wasn't joking. He looked at me with fear in his eyes, and he told me that he thought something was wrong. I checked his vitals, and they were normal, and I reassured him, but he kept pressing his call button. I kept checking. His heart rate was slightly elevated, but nothing that indicated an emergency. I paged the surgeon, and he promised me he would check in on Tom when he came down for rounds. But I knew that something wasn't right, and by mid-morning, the surgeon had ordered a chest x-ray, and Tom was sent down with an escort. I went about my shift, waiting for the results. Then I got the call. Tom had died. A massive aneurysm had ruptured when he was on the x-ray table. One moment he was worried and reaching out for help, and the next he was gone. I can't tell you how many times I've replayed that morning in my mind. I knew something was wrong, but there was no way to prove it. No test, no monitor, no piece of data could validate what my gut was telling me. I was a nurse with knowledge, experience, deep connection to my patient, but at the beginning of my nursing career, my clinical judgment just wasn't enough. That moment has stayed with me my entire career, and I know I'm not alone because every year, over 250,000 people in the US alone die from adverse events. It's the third leading cause of death in the US behind heart disease and cancer. The World Health Organization recently reported that more than 3 million deaths occur each year due to unsafe care. Today, I want to tell you about what's changed and what hasn't, because now we have something that we didn't have back then. We have a system called Concern. Concern stands for Communicating Early Concerns Entered by RNs. Concern translates nursing clinical judgment into data-driven signals, warning us when patients are beginning to deteriorate with enough time to act. Unlike traditional early warning systems, Concern processes structured and unstructured data, examining not just vital signs, but also the nuances within nursing documentation patterns. So here's what we've learned from years of research. When nurses are worried about a patient, they don't always say it outright, but their actions speak volumes. They start spending more time at the bedside. They document vital signs more frequently than what's required. They administer as needed medications more frequently, and they withhold standing medications. They start using key phrases in their notes like MD aware and EKG obtained. These subtle behaviors are signals. They're not random, they're not emotional, they're data-rich expressions of nursing judgment. And that is what Concern listens for. By integrating these signals from narrative notes and clinical actions, Concern detects when a patient is starting to deteriorate, often hours before traditional systems pick it up. That lead time It's a window of opportunity. It's a chance to act, to intervene, and to change the story. Here I highlight the immense scale of the concern data set, which contains 218 million rows of nursing flow sheet data alone. It really drives home the point that nursing data is without a doubt a form of big data. We spent the first 2 years of our project building and testing the concern early warning system. We have separate predictive models for ICU and for acute care units, and the accuracy is decent for both. These statistics demonstrate the robust performance of the concern acute care early warning system in predicting critical outcomes, making it a reliable tool for early intervention. In developing the concern early warning system, we anticipated that demographics, especially race, could impact the accuracy of risk predictions. To address this, we integrated demographic data into the model building and the post-processing steps, ensuring that race didn't unduly influence the score. Our goal was to reduce racial bias and create a more equitable system. When comparing concern with established early warning systems like the News and the Muse, we found a critical difference. These early warning systems don't account for racial bias, and research reveals that white or Caucasian patients often receive much higher early warning system scores, especially when it comes to early ICU transfers compared to Black or African American patients. So this suggests that race is embedded in the way that these systems function, potentially leading to unequal care. By incorporating demographic data into concern, we aim to reduce this bias and to ensure that every patient, regardless of race, receives timely and appropriate care. This work not only improves patient outcomes, but it also sets precedent for making healthcare technology more inclusive and more equitable. In healthcare, as in many fields, it's important to routinely assess the systems that we build for fairness. Our efforts with concern highlight the significance of addressing bias and to create tools that can truly serve all of our patients. When we set out to create the concern early warning system, we knew that it had to be more than just a tool. It had to be a system that worked for the people who were using it, the nurses and the physicians on the front line. To ensure that, we embraced a user-centered participatory design approach. So this meant engaging directly with healthcare professionals throughout the entire process, from initial design to final implementation at the bedside. We started by collaborating with nurses and physicians to understand how they interpret clinical documentation patterns. Their insights were invaluable in shaping the way that the system identifies early warning signals. So together, we defined what constitutes high, medium, and low thresholds for the concern early warning system scores. By involving them in these critical decisions, we created a system that's well aligned with real-world clinical practice. But it didn't stop there. We also focused on designing a concern app to enhance communication and decision-making within the care team. We wanted to ensure that the app didn't just provide data, it had to make it easier for teams to collaborate quickly and effectively, with features that allow nurses and physicians to easily track patient status, to communicate alerts, and to make decisions together. The app fosters a more coordinated and responsive approach to patient care. In the end, the success of concern hinges on the fact that it was built with the people who will use it. The input from nurses and physicians guided every step, ensuring that the tool wasn't just technically advanced, but truly practical and useful for team-based care. When designing the EHR integration of the concern early warning system, one piece of feedback stood out. Nurses and physicians were adamant: no more pop-ups, no more annoying alerts. They emphasized that while alerts can sometimes be helpful, more often they disrupt workflow and become just another source of frustration. Instead, they suggested something more integrated and seamless. So we took their advice seriously, and instead of designing intrusive pop-ups, we embedded the concern level directly into the patient list. This way, clinicians can see a patient's risk level within the context of their existing workflows. It's right there, alongside other patient information, where they need it and when they need it. For those who want more detail, we also developed the Concern app, which provides deeper insights and a more comprehensive view. By keeping things integrated, though, with their clinical workflow and documentation patterns, it made it easier for clinicians to make informed decisions without interrupting care. This user-centered design approach was crucial. It's a reminder that technology should enhance rather than hinder the work of healthcare professionals. And by designing with the end user in mind, we were able to create a system that feels like a natural extension of the healthcare team. After years of research and collaboration, we conducted a clinical trial in 2 healthcare systems in the United States, Mass General Brigham in Boston and New York Presbyterian in New York City, to test the effectiveness of the Concern early warning system. The results were both powerful and promising. On Concern intervention units, we saw a significant reduction in inpatient deterioration events. The average length of stay dropped 11.2% from 7.2 to 6.4 days. More importantly, though, we observed a 35.6% decrease in the likelihood of in-hospital mortality, meaning that less patients were at risk of dying. The risk of sepsis, which is a life-threatening condition characterized by infection and multiple organ failure, also decreased by 7.5%. So in other words, patients on Concern units had a better chance of avoiding this dangerous condition. Overall, there was a 6.4% decrease in the likelihood of any major adverse event, reducing complications across the board. But perhaps most encouraging were the outcomes that truly reflect better care. While we saw a 24.9% increase in unanticipated ICU transfers, this is not a negative outcome. It means that Concern was able to identify patients at risk early, ensuring that they got the intensive care they needed before it was too late. And here's the best part. There was a 10.7% higher probability of patients being discharged alive, which means that the Concern early warning system didn't just help reduce deterioration, it saved lives. These results demonstrated the tangible impact of integrating AI into healthcare to predict and to prevent deterioration. The Concern early warning system didn't just improve patient outcomes, it redefined what's possible with early warning systems. I started my talk today with a very sad story. Today, that story could have a different ending. Now we have AI-powered early warning systems like Concern, a tool that detects subtle, hidden patterns in nursing documentation to predict patient deterioration before traditional vital sign approaches would show a problem. If I had Concern back then, it might have flagged Tom's condition sooner. It might have given me the evidence I needed to push harder for immediate intervention. It might have saved his life. But Concern is more than just an early warning system. It represents a vision for the future of nursing. In this future, AI doesn't replace nurses, it amplifies us. It sees what we see, and then it helps us act faster, more confidently, and with evidence to back us up. It turns nursing judgment into information and information into action. Because the truth is that nursing has always been predictive. We know when a patient is not right, often before the vital signs change. What we haven't always had is a way to make that knowing visible to ourselves, to the team, and to the system. And that's what we built. And we built it with nurses. At every stage of design and implementation, nurses shaped how concern works, what it shows, how it communicates. We made sure that the system speaks a nurse's language, not in abstract metrics, but in clear, actionable insight. It's what user-centered design looks like when nurses lead it. And we didn't stop there. We looked very carefully at equity, at how risk models can reflect bias, and how important it is to train AI on diverse, inclusive data, because predictive power means nothing if it doesn't serve every patient equitably. So imagine what it means, imagine what concern would mean in an understaffed hospital or a rural clinic where early intervention could mean the difference between transfer and tragedy. The future of nursing powered by AI is not a high-tech fantasy. It's a human-centered reality, one where our deepest strengths, which are clinical judgment, presence, and advocacy, are lifted up by innovation. We are standing at a pivotal moment in healthcare. We can choose to see AI as a threat, or we can embrace it as a partner, a tool that strengthens our clinical judgment, sharpens our decisions, and helps us do what we do best, save lives. Because every nurse, every doctor, every healthcare professional has had that moment, the moment when we just knew. The difference now is we no longer have to wait for proof. With the right technology, we can act. And when clinical judgment meets innovation, we don't just care for patients, we save them. Thank you all for your attention. Before I finish, I want to take a moment to acknowledge the incredible team behind the Concern Early Warning System. The principal investigators for Concern are Sarah Rossetti from Columbia and Kenrick Cato from Penn. I'm the Mass General Brigham and Boston site PI. The project wouldn't have been possible without the hard work and dedication and the expertise of nurses, physicians, researchers, data scientists, very interdisciplinary team. All of us collaborated every step along the way. Our team's commitment to improving patient care and addressing the challenges in healthcare is truly inspiring. Thank you.